welcome. I'm Carol Jenkins, Executive Director of Cystic Fibrosis Research Incorporated, or CFRI, and this CF Discovery Series was developed in collaboration with Camille Wasowich, nurse practitioner at the Stanford CF Adult Clinic. It was designed to make vital CF information accessible to the CF community. Before I begin, I'd like to note that no information presented tonight is intended for a patient's diagnosis or treatment. As always, we urge you to work together with your healthcare team for your medical treatment. Tonight we look forward to our presentation, Your CF Pharmacist, a critical member of the healthcare team. We know we have attendees online, and if you wish to ask questions in the chat room, you must first log in to Ustream. Check our website for directions. Tonight we want to thank Genentech and CF Services, Inc. for supporting this important evening. Their support pays for the venue and refreshments, the studio we've constructed here, and other costs associated with the program. Tonight's program is being produced by your CFR Live team. That's Eric Martin, Scott Wakefield, David Suhu, and Joanne Davis, who is tracking questions from our online participants. We are live at the Crown Plaza Cabana Hotel in Palo Alto, and I encourage you all to ask questions, whether you're here in the audience or part of our online community. Hello especially to all of you who are in the hospital. We are so glad you can join us tonight. And finally, thanks to our volunteer, Alex, for serving food and helping with our cross-infection guidelines. I have the pleasure of introducing Kathy Yang, who is an associate clinical professor at UCSF School of Pharmacy in the Department of Clinical Pharmacy. Her specialty area is infectious diseases, particularly the treatment and management of multi-drug resistant infections. A wonderful note about how closely she connects with our CF community. Kathy has received an almost $2 million grant from NIH last year to study antibiotic dosing in cystic fibrosis, particularly determining the best dose of antibiotics to eradicate Pseudomonas aeruginosa from the lungs of CF patients. Please join me now in welcoming Kathy Yang.
Thank you, Carol. It's such a pleasure to be here tonight. It's so much fun always to talk with real people and patients and caregivers as opposed to our really boring healthcare teams. I hope to give you tonight an understanding of what it is that I do as an infectious disease pharmacist, but the main objective actually is hopefully to give you some tools on how you can take your medications safely and most effectively, and how your pharmacist, as well as the other members of your healthcare team, can help you do that. So this is where I work at the UCSF Medical Center in San Francisco. We are a tertiary care medical center with over 300 beds, and we specialize in transplantation. So there are multiple services which include bone marrow transplantation and solid organ transplantation, which also includes lung transplantation. And this is only one of the many campuses that we have, and in 2015 we're actually going to be opening a women and children's hospital at Mission Bay as well as a cancer center, so it's all very exciting. So what I wanted to talk about tonight was really your care of CF with your healthcare team. And as you can see from this picture here, that your CF care team is really big. There is the physician, the nurse coordinator, the pharmacist, the dietitian, the social worker, the physiotherapist, the respiratory care therapist, and most importantly, you're right in the middle. So you really are the driver of your healthcare, and you actually put all the pieces of this puzzle together. So your job is to stay the most informed in your care, to know all the details that you can, and to make sure every member of your team knows everything that they need to know about you. So what does the pharmacist do? The traditional pharmacist, I love this picture because it's something I saw when I was a student. The traditional pharmacist was traditionally just dispensing, count, pour, lick, and stick. So how much did you really have to know? So if you count by fives, you're good, right? And what I love about this picture is the fact that if you can tell, the pharmacist is behind the counter just putting pills in bottles. And that's not really what we do today. So today's pharmacists are experts in medication management. And this is a good friend of mine, Marilyn Stebbins. She's also a faculty member at UCSF. And in this picture, you can see that she's counseling a patient on his medications. There's no pharmacy in sight. There's not a pharmacy behind her. There's no pharmacy on the premises. But she's going over every one of his medications with him to make sure that he knows what each one is for, how it's taken, and what to do if he gets into trouble. So our guiding principles are really to identify, prevent, and resolve drug-related problems, and these can be side effects, drug interactions, making sure you take them correctly. So one of the things we will talk about tonight is medication adherence, which is a big deal when you're dealing with a chronic disease. Being able to take your medications is a huge thing. We encourage the proper use of medications and general health promotion and education, meaning that we're a great resource for information. So we are a resource for physicians in the hospital and in the home care setting, but in the community pharmacy, we have a lot of patients that just come up and ask us questions about, what do you think of this herbal medication? Or, I think I have a cold. What is the best over-the-counter cough medicine I should use? So these are all questions that your pharmacist can answer for you. And in multiple studies, pharmacist interventions have been shown to improve patient health care outcomes and satisfaction. And part of that reason is because pharmacists are fairly accessible. They're in a pharmacy, they can be there 24 hours a day. You can call them in the middle of the night and someone will always pick up the phone. So one of the things that we really focus on in cystic fibrosis, as well as any chronic disease, is treatment adherence. And treatment adherence really just means that you take your medications the way you're supposed to, you don't miss any doses, and you stop your medications when you're supposed to. So for instance, if you're taking an antibiotic, you don't skip your doses, and you finish the entire course. That could be 10 days, that could be 14 days, that could be 6 weeks. So specifically in CF, we know that treatments intensify as the disease progresses. So as the disease gets more complicated, there's more medications added on. And as more medications are added on, medication adherence goes down. So people find it harder to take their medications. And this is a table showing what the adherence rate is for each type of intervention. And this is out of the Journal of Cystic Fibrosis. And you can see physiotherapy and vitamins have the lowest adherence rate for CF patients. And part of that is because patients don't immediately feel the benefit of physiotherapy or vitamins. You take a vitamin and you don't all of a sudden feel pumped up. So because they don't feel an immediate health benefit, they're hard for patients to stick to. Antibiotics have the best treatment adherence, probably because patients feel that they're doing the most good. So it's something they have to do. They have an acute event. They have to finish that therapy to stay healthy. So we also know that non-adherence increases with age and severity of disease. Age, because as you'll see, when kids have CF, their parents are parents are parents. So they make sure kids take their drugs. They're on top of them. They make sure they do their inhalers, they do their nebulizers, they take their antibiotics. As patients get older, they tend to not feel the benefit of that. And there's a huge drop-off in the teenage years. And that's because teenagers are teenagers. So they become more ingrained in their care, they become more responsible for their care, and as they become more responsible, things tend to drop off. And as you know, teenagers' body image is very, very important for teenagers. So there's a little bit of, I don't know if you'd call it shame, but they don't want their friends to know they have cystic fibrosis. So they miss their therapies because they don't want their friends to know that they have to do that nebulizer treatment or they have to go home and do their physiotherapy treatment. They just want to be a normal teenager. So that's a point in a person's life when it's really important for parents to sort of stay on them and say, okay, you're in this big transition in your life, you're becoming an adult, you're much more responsible for your care, so you have to be a responsible adult. So when we look at other reasons for non-adherence in CF, this is actually really interesting because it varies, again, depending on the type of treatment we're talking about. And when you ask patients why they don't do their therapies, the number one thing they say is they don't have enough time. So physiotherapy and nebulizers take a lot of time. You know, you have to do it multiple times a day, and if you have to do multiple nebulizers, you have to sequence them, you have to wash the machine. It takes a lot of time. And hey, we all have busy lives. We don't have time to do that. So that's the number one reason. Another reason is I don't think I need it. I feel well without the treatment. And that's again because patients don't feel the immediate benefit of things like physiotherapy or nutritional supplements. It's not like the cartoon where you take a can of spinach and all of a sudden you beef up. So they don't feel that immediate benefit. It makes it very hard to stick. And it interferes with my social life. Again, this is something that is much more an issue when you have adolescents and as they transition to adulthood and they have jobs. And lastly, I simply forget. I mean, I forget to take my vitamins every night. So that happens to all of us, but the reason I put this up is because these are all things that having a good open communication, a good dialogue with all your healthcare providers, and especially your pharmacists, can help you sort of work your treatments into your lifestyle and not work your lifestyles into your treatments. Okay. Another thing we focus on all the time as pharmacists are medication adverse events. So these are some scary numbers. 82% of American adults take at least one medicine. 29% take 5 or more. And when you look at adverse events, there are over 700 ER visits and 120,000 hospitalizations due to adverse drug events per year. And what do I mean by adverse drug events? That's just basically a fancy word for something happened that wasn't supposed to happen. So it can be a side effect, it can be an allergy, you fainted, it can be any of those things. And a rash, that's probably one of the most common adverse events. So these cost a lot of time and money, $3.5 billion in medical costs per year. And the scary part of this number is that at least 40% of these are preventable. And there's something, these are things that we should be focusing on to prevent people from having to go into the hospital. And these numbers are expected to grow, especially as our population ages and people take more medications. So what about in children? So medication adverse events in kids are equally, if not more scary. Over 600,000 ER or clinic visits per year due to adverse drug events. Most of these, again, are rashes or some type of drug allergy. Children less than 4 years old are at the highest risk, and this is because children's first exposure to drugs is usually an antibiotic. And this is when you figure out that your child has some kind of penicillin allergy or some sort of amoxicillin allergy. And the typical scenario is the child who gets an otitis media or an ear infection and has to go get antibiotics, and on their first or second doses they get a rash. The most common antibiotics that cause adverse drug events are cephalosporins and penicillins, which are frequently used in patients with cystic fibrosis. So these are things that we need to be aware of, and I want to give you some tools to figure out how you can avoid these things or how you can take your medication safely. So transitions of care. This is a really hot topic in medicine right now. And transitions of care basically means the patient is moving through the healthcare system. And they're moving through the community to the acute care setting, which is hospitalization, and then they move back into home care and then back to community. So all of this transition is an opportunity for a medication misadventure. And what I want to highlight is that pharmacists are integrated at all levels of care in this transition. And one of our jobs is to hopefully keep any of these misadventures from occurring. So this brings me to my next topic, which is medication reconciliation, which is a very, very fancy term for basically making sure that every patient gets the medication they're ordered at the time they're supposed to get it. So it's comparing a medication order to all the medications that that patient is taking. And believe it or not, that is something that is not very easily done in our healthcare system, because our electronic medical record system doesn't really exist. So our systems don't talk to each other. So if you have a patient coming from the community into the hospital, the only way the doctor in the hospital will know what that patient is taking is if the patient tells them. So it's up to the patient to know exactly what their medications are. And this isn't easy considering how many physicians and healthcare practitioners a patient can see. They can see the dietitian, they can see the CF doctor, the pulmonologist, the diabetes specialist, the general medicine doctor. All of these doctors could potentially prescribe drugs, and it's not easy to let one doctor know what the other doctor prescribed. So medication reconciliation avoids inconsistencies in medication regimens such as omissions, duplications, incorrect drugs, dosing errors, and drug interactions. And this should be done at each transition, basically each handoff of care. So this new term is the handoff. So what is the handoff? So I'm sorry for any of the people who are not from the Bay Area watching. This is probably one of the most famous pictures in 49er history. So this is the catch. And basically, it was 1982, and it was an NFC title game. And it was the 49ers against the Dallas Cowboys, and the 49ers were down 27-21. And with 51 seconds left in the game, Joe Montana throws a 6-yard touchdown pass to Dwight Clark, who catches it, and they win the game. And the reason I put this up is because I couldn't find a very interesting picture of a handoff, so I had to go with the catch. But I think this is a really, really good metaphor for what healthcare should be doing at each transition of care. So at each transition of care, you have to pass the ball. You have to make sure the person is focused. They know what they're doing. They get all the information. Communication is the key. And you have to do this with all these competing distractions in the way. You're not going to get tackled in a hospital, but you get the idea. There's a lot of stuff going on. So it is really the patient's job to make sure that everything is correct and the handoff goes smoothly. So why do we need to do that? Medication errors. So 40% of all medication errors occur at the handoff. So what I mean by the handoff is as you move through the healthcare system, you have all these different transitions. You can go from outpatient into the hospital. And even within the hospital, there are many, many handoffs of care. You're transferred between floors. You go to the X-ray scanner, you come back. You go to the CT scanner, you come back. You go to the ICU, you come back. And then you're finally discharged. Each one of those transitions where you're wheeled down the hall or you go from one room to another is an opportunity for something bad to happen. So those transitions are where these medication errors can occur. And actually one study looked at medication discrepancies at hospital admission and found that when there were discrepancies, 6% of them had the potential to lead to serious harm. Thankfully, the majority of them do not, and that's because those discrepancies are things such as a medication was left off or a dose was incorrect. So even though it's a discrepancy, it's not a life-threatening event. But you can see that it could be with very serious medications or very critical medications or medications that have that need tight control, such as insulin or anticoagulants, where you have to be very precise in therapy. So you can see that there can be a potential for medication error and harm. So what do I do in the acute care setting? This is about pharmacists, so I'll try to talk a little bit about pharmacists. In the acute care or hospital setting, the traditional role, again, was medication distribution and control. So the inpatient pharmacist would receive the order, they would check it to make sure there's no drug interactions, they would check it to make sure the dose is correct, and the medication would go to the floor. That's only a very, very small component now of what we do. So one of the big things we do now is medication histories or reconciliation, so having a really in-depth conversation with the patients to make sure that every medication that the doctor prescribed is correct. We didn't leave anything off out of your outpatient regimen, or if we did, we know about it, and we know what pharmacy you went to, we know what your allergies are, we know what drugs you can tolerate and which drugs you can't. The other thing I do is we monitor for efficacy and side effects. And because I'm an infectious disease pharmacist, my world revolves around antibiotics, antifungals, and drugs for viruses. So that's my world. So everything that I monitor revolves around those three classes of therapy. And so those drugs also have the high potential for side effects, such as rashes, people throw up, they get low blood pressure sometimes when they receive them. So my job is to make sure none of that happens. One of the things I do as an infectious disease pharmacist is I take a lot of consult questions from physicians or nurses on the floor about choice of therapy. So a very common scenario is I get a question, a phone call on the pager from a physician who was on the general medicine service, and they've admitted a patient with CF. And the patient may have grown a Pseudomonas that has a strange susceptibility profile and is somewhat resistant, but not all the way resistant. The patient may also have some underlying kidney function issues because of their other meds or because of their underlying diseases, or they may have a lot of drug allergies. So the doctor will call me and says, I've grown this bacteria, it has this resistance profile, and the patient has this type of intolerance to medication. What is the best antibiotic I can give? And then it's my job to sort of piece that together and come up with a regimen that fits that patient. Nobody's ever the same. I also do what's called dose optimization, and that's pharmacokinetics and pharmacodynamics, and I'll go into that in a sec. I do a lot of drug information and education to physicians as well as to patients. So a lot of times I'll get a phone call from a doctor that says, I have a patient who took this antibiotic and started feeling dizzy, had like an outer body experience. Is that a side effect? And so then it's my job to tell them how likely that would be a side effect from the drug, the antibiotic they're taking versus maybe 3 or 4 other drugs they're receiving. I do a lot of medication counseling to the patients as well, and there's a lot of discharge planning and follow-up, which of course again includes the handoff. So making sure that we've put all the patient's medications in order. If they need to go home with home care therapy, their IV home care therapy is set up. They know exactly when the home care is supposed to visit. They know exactly how to take their medications, etc. So dose optimization. This is one of my big jobs. And basically what I do is I figure out what is the best dose for an individual patient. And it can be an adult, it can be a child, it can be someone who has bad kidneys, it can be someone who has maybe a liver transplant or a kidney transplant or even a lung transplant, and they have different immune suppressive drugs on board. So there's a lot of drug interactions. And basically, there's always some type of interaction between the bacteria and the patient. The bacteria goes somewhere. And for CF patients, it's mainly the lungs. So I have to figure out, okay, so I know the bacteria is in the lungs, and it's got a resistance profile of some number. I know how antibiotics work in the body. I know where they go. I know how they're metabolized. But what I need to do is figure out, for that specific patient, can they tolerate that drug? If I was to push that drug to the highest dose possible, could I do that safely without hurting the patient? Or if I can't do that, do I have alternatives? Can I come up with some kind of antibiotic combination that will treat multiple organisms and still be safe for the patient? And at the same time, that antibiotic has to be as targeted and as specific and active against that bacteria as possible. So that's what I do on a daily basis. So I figure out what drug fits what patient and make sure that drug also fits the bug. And that is how we optimize the drug and make sure that we get the best possible clinical outcomes for the patient while reducing side effects. Okay, so pharmacists in home care. Again, one of their main jobs is to receive the handoff. So they get the information from the hospital discharge of what the patient needs. there's always ongoing medication review. So even if a patient is in home care for 6 weeks, weekly, there should be a review of all the medications, make sure nothing's changed. There's an influx of information that comes in from the doctor. There's also an influx of information from the home care nurse that sees the patient. They take all that information and make sure it still works. They also are the ones that do all the preparation for the IV drugs, their respiratory drugs, and for some patients who need it, for feeding tubes, enteral therapy preparations. A lot of counseling and education goes on. So there's always an on-call pharmacist in the home care that can answer questions about, hey, I took this antibiotic, I dripped my IV in, but I think my IV line might have fallen out, what do I do? Or only half the drug went in and it somehow stopped. What should I do? Should I call someone? Should I go to the ER, etc.? Insurance issues. So not all home care is covered by insurance, and home care pharmacists are really savvy at knowing how to eke that information out and get you what you need. And they're, of course, liaisons with your physicians, again, with the handoff. Community pharmacists. This is my favorite topic because I think we don't give them enough credit. Community pharmacists are by far the most accessible healthcare practitioner in the community. You see them at the Walgreens, the CVS, there's 24-hour pharmacies everywhere, and they're very accessible. They're always available to answer questions. You see them behind the counter, but if you ever ask them a question, they will always come out from behind the counter to meet you in the aisle and talk about whatever you need to go over. So again, they take the handoff, the discharge medications, they make sure it looks appropriate, they again do medication review, ongoing counseling and education. Every time you come in for your refill, that is an opportunity for you to ask your pharmacist about your medication, and they should be going over your medications again to make sure you're still taking it the way you should. Self-care. So self-care is basically over-the-counter medications. It's a huge industry, so most people don't want to go to their physicians. So if they get a cold, if they burn themselves, the first place they're going to go is the pharmacy. Dietary supplements and herbals. So again, a huge industry, and they know a lot about that. Insurance and cost issues and access and continuity. So if you have a hard time getting your medications, your community pharmacy actually has a lot of information on other places you can get meds, and which are good, reliable sources and which are not. And the other thing that community pharmacists do that I don't think people realize is they do triage a lot of people. So when I worked in a community pharmacy many years ago, I would see lots of patients that would come in and say, I have this going on, I have this burn, what do I do? And sometimes I would look and say, okay, you can treat that yourself. Sometimes it's go see your doctor, and on a few occasions it's go straight to the ER. So if you're never sure, ask the pharmacist. They will never tell you to treat something over the counter that is not appropriate to self-treat, hopefully. Okay, so this is a good example also of what pharmacists have done in diabetes management, in asthma management, and also in cholesterol management. And this is something that's very famous in the pharmacy literature. It's called the Asheville Project. And basically, Asheville is a city in North Carolina, and within the city government has paid for their employees to go see their pharmacists on a routine basis for long-term care of either their diabetes or their cholesterol, or in this case, their asthma. So in this study, they had 252 patients, adults and children, with asthma who were seen in 12 different pharmacies in Asheville, North Carolina. And they were followed for a fairly long time, 5 years. And in this program, the employers said it's an entirely voluntary system. You don't have to go if you don't want to. But if you do go, we will give you a little bit of medication incentive. So we'll pay your copay. We'll pay your $5 copay for your medications if you go. So patients who went received one-on-one asthma counseling by a hospital or community pharmacist. And the initial consultation was fairly long, 60 to 90 minutes. And what they did was the pharmacist would go over their medications and then have them come back as needed for routine follow-up. And on average, people came back every 3 months or so for about 30 minutes. And so what did the pharmacist do? they would create a medication action plan, basically a plan to use, how to use your meds, when to take them, what to do if you miss the dose, how you sequence them with other meds, et cetera. There was a lot of time spent teaching patients how to properly use their inhalers or their nebulizers. Then there was a lot of assessment of their technique and reassessment. So it's not just, let me show you how to use this inhaler, is why don't you show me how you've been using your inhaler? And during that interaction, pharmacists spent a lot of time correcting techniques on how to use their pulmonary devices. And they also asked questions about symptom frequency, triggers, and they looked at the results of their objective measures, such as peak flow meter results. And then they sent the recommendations on to the physicians. And sometimes these recommendations were keep a steady course. Sometimes they were, this patient didn't really understand how to use their medications, and this is what we did. Or this patient didn't have good control of their asthma. We would like to add a second agent, or we would like to increase the dose. And what they found over 5 years, that all asthma symptoms improved in all the patients that went into this program. And objective measures such as FEV1, which is looking at peak flow, those also improved. ER visits went down from almost 10% to 1.3%. And spending on asthma medication, interesting, went up, but all other healthcare costs went down, and hospitalizations went down too. And this led to a direct cost savings of about $725 per patient per year. But if you include things like missed days of work, that number actually went up significantly to almost double. And there was a lot less missed days of work in these patients who went into this program. So it really proved that pharmacists could really manage these patients with all kinds of disease states, including asthma. So helping you get the most out of your meds. So what should you do when you go to the pharmacist? So things that they should always be doing with you is counseling and education. If you're not sure how to use your inhaler or your insulin, or if you have difficulty taking your medication, this is the time to ask. And actually, most patients coming into a pharmacy are just, give me my drugs and let me get out of here. They don't want to stay. But if you take a few minutes to stay and show the pharmacist how you use your medication, how you inject your insulin, how you take your inhaler, you can get some really good tips on how to optimize your therapy. What I mean by hard to take meds are, we all have children who, you practically have to sit on them to get their meds down. Some meds just don't taste good, they're really big, or they're just yuck. And there are lots of tricks that we have to help meds go down. And these include not just the things like, putting syrup in the medications, which a lot of the pharmacies can do, but how do you hide your drugs? So hiding it in in some Nutella, or icing your mouth with a really cold juice before you sip it through a straw. Those are all things that will help you get your medication down, and tips that you can get from your pharmacist. Herbal and dietary supplements. There's thousands of them out there, and it's a huge industry. How do I choose which is the one I should take? How do I know they're safe? And what is the medical evidence that supports their use? And so these are really good questions to ask the pharmacist. I know a lot of people look for this type of information on the internet, but we'll go over whether or not that's always the best thing to do. And cost issues. Do I have options if I can't afford my meds? Should I mail order my meds? For most CF patients who are on chronic medications that are stable, mail order is a great option. It's cheaper, they come straight to your door. You never have to leave the house, you don't have to go to a pharmacy. But you will have to go to the community pharmacy, likely for whenever you start a new medication. And that's your opportunity to sort of get your education about the medications before you sort of transition into this mail order pharmacy state. What about pharmacies online? I bet you didn't know that the National Association of Boards of Pharmacy actually looks at all these online pharmacies, and there's over 10,000 of them out there. And they have accreditation standards that these online pharmacies have to meet. And just, I think last year, the NABP came out with a listing of what these accredited pharmacies are. So if you go to nabp.net, they will actually tell you which are the pharmacies that are, credible and reliable and which ones are not. And they have this really amazing statistic that over 97% of the online pharmacies that are out there do not meet Board of Pharmacy standards. So it's really important for you to look where you get your medications from if you intend to buy online. Is there something else I can take? If you are prescribed a name brand medication that's very expensive, do you have options to take a generic? If there's no generic, can I take something else? And these are questions that you can ask the pharmacy about things which we call therapeutic interchange. So is there something else I can take in its place? And should I split my pills if I can't afford them? And this is something that Kaiser used to do routinely. If you have to pay $5 for a copay for a 40 milligram tablet, and you only need 20 milligrams, if you pay $5, you've now got 2 months worth of drug. But you should know first if that's a safe thing to do, because not all medications can be split, and not all doctors want you to do that. Okay, and when you get your refills, you should recheck to make sure you're using your meds correctly. So talk to the pharmacist, make sure that the way you are taking it is really how it's intended to be taken. If anything changes, if you feel like you are having a side effect or you notice that you feel a little bit different, ask the pharmacist. Make sure you're not having a new adverse reaction. They also want to make sure you're getting the maximal effect. So do you need a dose adjustment? If you are somewhat controlled, but not all the way there yet, is there something else that you can do to optimize that therapy? And of course, all this information has to be communicated with all the other members of your CF care team. So what is your role? Again, ask the questions. Use the same pharmacy for all your medications if at all possible. And that's really hard to do, but even if you can't go to the same physical pharmacy, staying within the same pharmacy network, such as CVS or Walgreens, that's helpful because all of those medical records are linked. So if you are prescribed a new drug, your pharmacist can then go back and look at all your old drugs to make sure there's no new drug interactions and there's no duplication and that everything is as it should be. Make sure your pharmacy has a complete profile of all your medications, and this includes things like over-the-counter drugs and also things like herbal medications, because those also can have drug interactions. And the last thing is to brown bag it. So make an appointment with your pharmacist. Go home, open your medicine cabinet, throw everything into a bag, take it to the pharmacy, dump it all out on the counter and said, this is what I have in my pharmacy. Help me figure out if this is the right thing. And they can tell you if you have expired drugs, if you have duplications in your therapy, if you have drugs that have been recalled, or things that you don't need anymore based on your current profile. So just throw everything on the counter and they can help you go through that. So what's the most important thing that you need to have? And it sounds really simple, but the most important thing is a medication list. So this sounds very, very basic, but because our healthcare system uses medical records that don't talk to each other, it's really up to you as the patient to have control of this. So you should carry an accurate and up-to-date medication list. Take it to all your medical visits. So if you go see the pulmonologist, show them what you have. If they prescribe any medications, you put it on your list. Then when you go see your diabetes doctor, you bring the list and say, this is what my other doctors have prescribed. Make sure everybody is talking and all on the same page. And you update it regularly. This sounds really, really basic, but I'm going to tell you a very interesting story. So last year on Christmas Day, my neighbor texted me because his 89-year-old father was dizzy at home and had fallen down. So he wanted to know what he should do. So his 89-year-old grandfather called me, or his 89-year-old father called me, and I said, what did you do differently? And he said, well, nothing really. I take these medications for my high blood pressure, and I take all these different medications for my prostate, etc. And what had happened was he had gone to see his urologist, and the urologist had prescribed him a medication for his prostate. And one of the side effects of that medication is that because it opens up your blood vessels, it can give you the potential to have what's called orthostatic hypotension, where when you stand up, you can get a little bit dizzy. And before, when he didn't have that, his blood pressure was controlled, he was perfect, he had no side effects. But once that medication was prescribed, it was just enough to tip him over the edge that it made his blood pressure too low. But his urologist didn't know what his cardiologist had prescribed, and the cardiologist did not know what the urologist had prescribed. So they didn't talk, and because of that, he had this adverse drug event. So he asked me, what should I do? And I said, don't take the prostate medication, go see your doctor, make sure they know, and readjust your medications. And that's what they did, and of course now he's fine. So what should you put on your medication list? This is an example of a list, and I got this from the American Society of Health System Pharmacists website. This is by no means the only list you can have. Use whatever works for you, and if you go online and you Google medication list, you'll get tons of different templates. And some are really complicated and some are really basic. Some have a lot of information and some have too much information. So use the one that you feel comfortable, but pick one that you know you would update regularly. Some people have even taken to putting it on a USB card and just like sticking it in their pocket. Some people now do it on iPhone apps. So there's lots of different ways. The main thing is just to know what you're taking and to show everybody who asks you what your medications are. So what should you include? All your medications, how you take them, how many, when you take them, and when you're supposed to stop. And the thing about how many up here is really important because some things like pancreas, you take multiple tablets in a dose. So the milligram dose strength versus how many capsules you take don't always equate each other. So if you take, say, 20 milligrams of something and they come in 10 milligram tablets, you need to take 2. So you have to write that you actually take 2. And that's really important. So that's one of the biggest drug errors that people make is they assume the dose is 1 tablet, and it oftentimes isn't. Other things you should include, your oral meds, your IV meds, your inhaled meds. Sometimes people don't think of those as meds. All your scheduled drugs as well as your as-needed drugs. So things you need for symptoms relief as well as the ones you take on a regular basis. Your herbals and dietary supplements, and your vitamins and your over-the-counter drugs. And these are important because a lot of these drugs can have drug interactions again. And if you don't have a complete list, we won't know. So 10 things you should know about your medications. What is the medication for? How does this medication work? How am I supposed to take it? So here we have a bunch of pills on a spoon. So believe it or not, it's not all that intuitive. And these are things you should ask the pharmacist to make sure you're doing it right. How long do I take it? Is there a stop date? If it's an antibiotic, there's usually a stop date, and you should know what that is. And should I take it with or without food? And that is really important, especially for antibiotics. Certain antibiotics like ciprofloxacin or doxycycline, levofloxacin, they have huge drug interactions with things such as milk, dairy, calcium, iron. So any of those drugs have to be separated from any type of dairy product or over-the-counter product that has iron or magnesium or some kind of cation. So those are things you need to know. Otherwise, you won't get any effect from your medication. What are the side effects? What are the more common side effects I should be aware of? And if I feel something funny that, even though it's not on the top 10 list, but I feel it's a little off, where would I go for information? That's always something you just pick up the phone, call the pharmacy and say, I'm feeling this really funny thing. And they can look up to see how common or how likely that would be due to your medications. And they can direct you to whether or not you need to be seen. Are there interactions with other drugs, herbal medications, or dietary supplements? What activities should I avoid while taking this medication? Can I drive? Can I drink alcohol? Some antibiotics, you absolutely do not want to drink alcohol because it'll make you so sick that you'll be throwing up the whole time. What do you do if you miss a dose? And different medications have different guidelines. Some say if you're close to, if you're within 6 hours you skip it, or sometimes it's 4 hours. So it's different for every medication. And how should the medication be stored? Earlier I said you should empty out your medication cabinet, and that you really should empty out your medication cabinet, because you should never store anything in the bathroom, because there's humidity, it's wet in there. It's not the best place for pills, because pills are made out of dry compressed powder. So you should never store anything in the bathroom to begin with. But does it have to be refrigerated? Can I leave it in a cabinet? And if it's and maybe it's a drug that, if I don't use it for a long time, needs to be refrigerated, but if I do use it, I can leave it on the counter. So these are things you need to know. And lastly, I wanted to talk really briefly about finding health information on the web. So if you can't go talk to your pharmacist, where else can you go find information? So believe it or not, 80% of internet users look for health information online. And this represents something like 60% of the entire American population or something. It's a ridiculous number. And this is, if you ask people what they look for, this is what they look for. A specific disease or medical problem, a procedure, or they look up their doctor. And actually, that's something I think is really smart of people to do. You should always look up your doctor, look up your healthcare facility, because there are quality measures that are published online, and you can always see how your medical facility benchmarks against other facilities. And I love this quote: "Don't believe everything you read on the internet just because there's a picture with a quote next to it." I'm sure Abraham Lincoln would have said this if he had known. So how do you evaluate health information? The main thing is to look for sponsorship. Who runs the site? Is it sponsored by a drug company? Is it sponsored by a health organization? Is it a professional organization? Or is it an individual? A dead giveaway is always when it says .blogspot on the end. That's never a good thing. You want to see if there's a contact us link. Okay, there has to be a way that you can contact them to figure it out if it's reputable, and someone should be able to reply. And you should consider the quality. Who writes for the website? If it's a drug company, just because it's a drug company doesn't inherently mean it's biased. It means that they do have an agenda. Of course, they want you to buy their drug. But if it's medical information, the medical information should be written by a healthcare provider. It should be someone who is reputable. And is there a review board or editorial policy? Is this vetted by an organization or by a medical review board of some sort? Look for evidence. Is the evidence based on medical research or opinion? And does it rely on testimonials? So the problem is when patients have some kind of illness, they go online, and if you look online, you either see the best case scenario or you see the worst case scenario. You have these two extremes, and that's like 1% of what really goes on. And so most of the people, in the general public will do fine. But that is so boring to read that nobody really publishes that. So that's called publication bias. They only put out their testimonials when it's something that's really extreme. So just be very careful about that. Doesn't mean it's all bad, but it just means that you should take that information with a grain of salt. How current is the information? Is it based on latest research, and are there dates, and are there broken links? Beware of bias. So what is the purpose of the site? Are they trying to sell you something? Is it informational only? Who pays for the site? And are there a lot of ads? When you see a lot of ads on the side for pharmaceuticals or nutraceuticals, that's always a dead giveaway. Be critical. Are the health claims too good to be true? Beware of breakthroughs and secret ingredients, or things where you have to pay money for them to get the information from. And make sure you check more than one website. So if one website has this great information, Google it and see if you can find it somewhere else. If you can find it in a couple more websites, that makes it feel a little bit better than if you just see it on one or two. And is there a privacy policy? If they ask for personal information, what do they do with it? So that's all I have, and what I wanted to end with is this picture I took of Vernal Falls in Yosemite last year. And this Vernal Falls is, this waterfall is a great metaphor for public health, and it's actually very commonly used when we teach people about the role of public health in preventative medicine. And basically, the way our healthcare is set up is that if you can imagine people falling over the waterfall, you have all your doctors and your healthcare practitioners at the bottom of the waterfall fishing people out. Okay, so they're pulling people out of the waterfall as they come out and they treat them. Okay, the public health advocate doesn't do that. Okay, the informed consumer is not going to do that. The informed consumer is going to walk up to the top of the waterfall and figure out why people are falling into the waterfall to begin with. And so that is really what your job is. So if you're going to take your medications safely and effectively, you don't want to be the person at the bottom of the waterfall. You're going to be informed and be at the top so you don't fall in. Thank you.
I've really learned a lot, and could believe if there are any questions here, I will bring you the microphone. Are there questions online, or are there questions in the audience tonight? And it may well be that you have questions after you've had a chance to think through some of the information we've taken in today. Well, I have a question. I've recently learned that not all community pharmacies can provide either the same access to medication or the same expertise, say, as a total resource for instance, cystic fibrosis. Mm-hmm. Is that true? Are there different capabilities, different levels of pharmacy?
So most pharmacies, you're right, will not have expert services, as you're referring to. But a lot of pharmacies will have things set up like collaborative practice agreements where they work with specific medical centers or with physician groups to manage a piece of therapy. So take asthma, for instance. A lot of pharmacies will set up collaborative practice agreements where, once the physician sees the patient and has figured out what they want the patient to go on, they will hand off that patient to a pharmacist, and that pharmacist will then do the day-to-day management. This is actually something that's very routinely done in the Kaiser health system. So in the Kaiser system, the primary care physician will prescribe, will say, okay, I've seen this patient, may prescribe X, Y, and Z, and the next thing will be, referred to diabetes clinic. And at that point, then it's handed off to the pharmacist, and the pharmacist can then do the day-to-day manage and dose adjustments.
Thank you.
First question, any special advice for traveling with equipment and medication when traveling, especially by plane?
Yes, that's a great question. And actually, I have firsthand advice on that. One of my friends whose son was on a nebulizer packed it in the suitcase and flew to Alaska to get on a cruise. The suitcase was lost, and they got on the cruise without the medication or the nebulizer. And it was very traumatic. And cruise ships don't carry everything that you possibly need. So if it's something like that, you really should carry it as in your carry-on baggage. What a lot of people will do is carry maybe a certain amount in their carry-on and then the rest put in their suitcase, because if you tried to pack all of it, it might be too much. But for the most essential things, like the nebulizer, those are things you should try to carry on with you if you possibly can.
This will be my own follow-up question because I'm curious, but what about shipping it? I don't even know, can you ship medication? So if you carry some on and maybe ship some to your hotel or wherever your location is?
You can do that as well. If you do mail-out order pharmacy, you could definitely have that shipped over to the pharmacy or to the hotel that you're staying at. But if you're going to do that, you should call the hotel and let them know it's coming, and also let them know what type of storage requirements it would require. I mean, if something's coming refrigerated, you don't want it sitting there for a couple days before you get there. Yeah. Most people will likely just carry it with them. It seems like a lot, but it's probably the safest way to do it.
The next question from the online audience is, does it make a difference if you take albuterol and then Pulmozyme? Does the order matter?
Does the order matter? The order definitely matters. And usually, maybe you guys want to speak to this, since you do a lot of this as well, is there is definitely an order where if you're going to do things like Pulmozyme usually, I believe, goes first. Is that correct? Albuterol. Or albuterol goes first, I'm sorry. Then the other one, and then you usually do your antibiotics last. So the idea is to do your antibiotics last so that you've sort of opened up your airway, you've coughed up everything that you can, and then you get as much drug into your lungs as you possibly can. So the order definitely does matter. And make sure you use the right nebulizer for each type of drug. That seems like a simple thing, but certain antibiotics or certain drugs need special nebulizers. So you can't always mix and match them. You have to make sure you stay with the equipment it comes with.
I'm curious if the pharmacies are in touch with the pharmaceuticals that make the medicine. One reason I'm asking right now is for cost. What if the insurances don't cover what's been prescribed?
Right.
And what if pharmaceuticals might be able to help alleviate some of the cost? Is the pharmacist someone who would know about that, or would it be important for the patient to go directly to the different pharmaceutical companies and ask about what if the bill is too high?
Right. So that's a good question. And most drug companies will have what are called patient assistance programs. And even though consumers can call that line, usually they need the paperwork to be filled out by a healthcare provider. So it usually is a physician or a pharmacist. At UCSF, when we have these issues, the pharmacist sort of starts that paperwork while the patient is in-house. So by the time they leave, it's already been faxed to the drug company, and they've already in process. And usually the turnaround for that is a couple days. So it's not the easiest thing to do, and they make you jump through hoops. So they have specific requirements. For instance, I once did one where the requirement, although wasn't specifically stated, was you had to be a U.S. citizen. And even though it didn't state that on their application form, and the patient I had was not a U.S. citizen, when I called them on it, they said, you need a social security number. I said, it doesn't say that on your thing. And so I was noisy enough that they said, okay, we'll let you have it this time. But from now on, you have to be a U.S. citizen. So they don't make it easy. And information usually has to be done by the healthcare provider and faxed in with a doctor's signature, et cetera, for that to be in place.
Thank you.
A lot of drug companies that do antibiotics, they're more willing to do those type of patient assistance programs than things like the long-term meds. Because if you think about antibiotics, it's a finite course. So it's 2 weeks or 4 weeks or 6 weeks. So they're more likely to give those out for free than something where like you need an inhaler long-term.
Do you see any anticipated changes that might reform or where healthcare reform might affect pharmacies? I'm said that whole thing backwards.
Oh my gosh, we could talk about this for like the next year. There's a lot of reform going on with the healthcare movement, and one of the things is what is called MTM, or medication therapy management. So all those things that I talked about here, where you have this Asheville project where you have pharmacists managing a diabetes or CF or hyperlipidemia, these are all done in a community pharmacy, and the payment structure for those are not well defined. So even though pharmacists are doing that, most insurance companies don't actually pay for that service. So a lot of that is on a fee-for-service basis, and actually we have a program in Fresno that is run by our School of Pharmacy where our pharmacists are in the community doing that type of service with the elderly and disadvantaged patrons in the Fresno area, and they'll go through all their medications, come up with a medication action plan, et cetera. And although we can bill for that type of service, most insurance will not cover it. So that's a difficulty that actually is in the works through our healthcare movement. They're trying to, there's a lot of legislation to try to get that moving. And actually, I just saw an email about that last week where it's now in the California legislature as well.
Are there any further questions for now? Well, I really want to thank you and come up front and do so. So that I don't cross microphones. We're here at the CF Discovery Series with CFRI Live, and we've been listening to Kathy Yang talk about how pharmacies are a big source of information and counsel for patients. And that's another tool in our toolbox for best care, optimal outcomes with working with cystic fibrosis. And we're so glad to have had you tonight. This presentation is the last of our spring series, but do stay tuned to our website for more information on our other coming events, such as our National CF Family Education Conference in August, which is going to be followed by our Teen and Adult Retreat. In the meantime, before you take off for safe travel home, we have some evaluations to fill out, and we're so glad to have had all of you and all of you online join us tonight. Thank you very much.